Hello, I am Dr. Janice Williams. This lecture will be covering clinical documentation. The focus will be for clinical documentation for the advanced practice clinician. This is just an introductory lecture. This is not going to make you an expert in clinical documentation and billing. However, it will give you a good understanding of being a beginning clinician and how your documentation should align with your billing. Let's get started. So, what is clinical documentation? Clinical documentation is the way that you, the clinician, communicates your client's condition. It is the actions and the thoughts that the provider and the other individuals on the team have addressed the client's needs. It's important to remember that your documentation as a clinician includes those things that you have done and everyone else on that team. And that will make more sense to you when we get later in the slides and we start talking about the coding and the billing components. So, why do we document? Why is it important to do clinical documentation? One, we know it helps to improve the care, right? It also improves the ability of individuals to come behind us and understand our plan of care for the patient. And it helps us understand other people's plan of care for the patient. It helps to display anything that has occurred prior to our actual visit with that patient on that day. And it helps to support all the clinical decision making that we do for our patients. It enhances the efficiency and the effectiveness of care. And it also is important for security reasons, right? It helps us to demonstrate the evidence based practice that we are providing to our patients, and then validate what we have or have not done and clarify for some what that looks like. So, let's take a minute to talk about the different components that's important in clinical documentation, billing, and coding. I like to show this slide because it shows that when we are doing any documentation, it is a collaboration that is a part of a diverse professions and entities. It is not just about the healthcare providers and the healthcare team and our healthcare systems, but it also has this overlapping when it comes down to insurers, how insurers pay us, what services insurers will allow, what does the government say we should and should not do. So, when we are doing our clinical documentation, all of this needs to be considered, right? And of course, at the center of all of this is our patient. So, let's talk about some of the goals that we want to achieve with our clinical documentation. One, the importance of clinical documentation is being clear and concise. You all have probably experienced looking at a chart of a patient and seeing so much information or information that was not clear and concise that it was hard to follow the plan of care for that patient. So, we want to make sure when we are doing our documentation, we are very clear and concise with the information that we are putting into our patient's chart. It should include the history, diagnostics, what is our plan for that patient, and then how do we want this patient to follow up, right? What will be some of the things that this patient may need to do in the future? And in today's society where patients often see multiple providers, not only outside of different institutions or within different institutions, but even within one. So, making sure that our documentation is very clear is going to help us to provide the best care for our patients. Because in today's society, in our healthcare system, patients can go to diverse places to get their care. So, trying to make sure the care that you provide to your patient, your documentation is very clear, concise, and that If any provider or any other entity was looking at your documentation, they will understand exactly what your intent was. You can see here that there are many things that's included in our documentation to help us reach that clear and concisiveness, as well as help us to demonstrate what care we've provided, what care we are actually, or treatments we're recommending, and what we're thinking, right? So, just in case a different provider sees this patient in the future. So, let's talk about some of the policy recommendations for clinical documentation. One of the um, historical organizations that have developed quite comprehensive guidelines to assist us with documentation is the American College of Physicians. Some of their recommendations, they have some clear goals of what we're supposed to do with our documentation. Things like support patient care to improve the clinical outcomes through our communications and our documentation. Remembering that our patient charts and that information that we document, patients have access to it. Other entities may have access to it, right? And that it also is what is going to be the foundation when we and if we need to recommend our patient for other treatments, right? Getting prior authorization, the clarity of your documentation, your ability to articulate the medical necessity of why you are recommending certain procedures or why you may want a patient to be referred, you're going to need to make sure that documentation is very clear. Because if not, that may be a hindrance to your patient receiving care. It can not only prevent them from getting care, it may be where it just is a hindrance. So it delays the care that your patients will receive. Although many of us have found and continue to have challenges with electronic medical records, electronic medical records were created to help us to facilitate our communication with our patients, with other colleagues, with other specialties, both intraprofessionally and interprofessionally. So, trying to ensure that the documentation that you are doing in your electronic medical record is done in a clear, concise, and in a timely manner is going to be important. We also want to make sure that the documentation that we're doing for our patient is inclusive, that it is structured, and everything that we have in that patient's chart is necessary. We want to abstain from using language that may be offensive, that may be slang. We want to abstain from using any type of statements that if a patient or some other entity was to look at that chart, that they would be offended by what we said or unable to understand what we have written. That brings me to just a little sidebar when it comes down to abbreviations. I would caution you in using abbreviations when you're documenting. If they are not universal abbreviations, you should abstain from using them. Remember, everyone may not use the abbreviations the same. Therefore, it may lead to confusion in your documentation. It could lead to treatments or services being inappropriately administered or not administered because there's not clarity on what is being understood by that abbreviation. So I would tell you be very cautious if you are one who likes to use abbreviations. So let's talk about some of the recommendations for using electronic health records. Some of the recommendations by the American College of Physicians is that our electronic health records should facilitate the healthcare delivery, and it should include the team. So remember, you may be the provider, but that electronic health record is going to and probably does contain the communication between other disciplines such as social work, nursing, radiology, and so forth. So know that the electronic health record, it has enhanced our ability to care for our patients. But with that being and understanding where and how your documentation is going to be seen by others. It supports us as a clinician in our decision making process. It is also a reusable documentation. It can be used for other providers, maybe looking at our documentation and determine how they want to proceed with care. So you need to make sure that what you document is true and honest and that you're comprehensive. But also, as nurses, we learned if it is not documented, it is not done. And although we do want to make sure that our documentation is clear and concise, we want to try to avoid redundancies, repeating the same thing over and over again, because what that can lead to is over documentation, which can also be a problem. If you over document, one, you can open up yourself for litigation, right? Because in one place you may say one thing and another something else. It also makes it cumbersome and hard for the person reading the chart to understand. And think about it this way. We are in a healthcare system where time is of the essence. So if you are over documenting and it's not clear and concise, it may take individuals an extended amount of time to read through your documentation, thus delaying care. Or individuals may choose not to read the documentation and they may miss key parts that's pertinent for the well-being and the treatment for your patient. So it's a fine balance, and understanding how to document and how you can be as clear and concise in your documentation is a skill that you will improve on as you begin to document more. Also, integrating the client-generated data, right? This is understanding the importance of the confidentiality in HIPAA. Understanding there's going to be information about that patient that is specific to that patient. So we need to make sure that we are honoring the regulations of our institution and respecting our patient enough to keep their information confidential. I like to say things as simple as when you're documenting, making sure you're not leaving the charts open and walking away where somebody else may be able to have access to it. If you have to, for any reason, document on paper, that those papers are put in a secure place. And if you're receiving papers from a patient, think about a patient who may be seeing you after a hospital visit. Ensuring that you're not leaving that paperwork laying around where others may see it, and you're only sharing that information with those that it is important for. I would like to now transition. I've talked about the importance of documentation, not only for you as the clinician, but all the other entities that we work alongside with. Not only the healthcare system, but we got to think about the government, we have to think about the insurers, and definitely we must think about the patient, right? Let's now move to some of the things that drive how individuals document, how providers document. They kind of put it into three categories. We have defensive medicine, and we'll go into that a little further. We have electronic medical records, and then we have what we call the evaluation and management guidelines. We're going to talk about the evaluation and management guidelines a little bit later, and those are the details that talk about how do you evaluate the documentation and do your billing and coding, okay? But we will get into that a little bit further in this lecture. So let's now just kind of dig a little deeper on the three different types of documentation. Think about defensive, and it is exactly what it sounds like. This is when you're writing, understanding that there may be legalities that may occur. So you want to document as if a lawyer was looking at your chart. However, you don't want to over exaggerate because you're concerned about legal action, or you're thinking about lawyers looking at your chart, right? So being a little bit aware that our charts may be looked at for legal reasons, for litigation, is important. However, not allowing that to lead you to overcompensating and writing too much or not writing enough. Okay? And so when you think about defensive documentation, you're thinking about making sure your chart is legible, abstain from the extensive documentation. You do want to document your pertinent positives and your pertinent negatives. Okay? You also want to reduce the extensive documentation or the excessive documentation. There is also what we call problem oriented. This is where you have extensive documentation. It improves the organization and it improvement of care that is provided by the team and its colleagues. Problem oriented. So think about a patient who may present to you with diabetes. So you as the clinician may do your documentation based off of treating that patient with diabetes, whereas your nurse educator may document based off of them educating your patient about the diabetes or teaching them how to use their diabetic equipment. You may pull in a social worker. You may have a nutritionist. So that's when you're thinking problem oriented. There is a problem that you're addressing and you're going to document for that. And then we also have what we call our E&M guided documentation. This is when externally verifiable measures are looked at. It is defined, but not by what was done, but what is documented. I'm going to say that again. It is defined not by what is done, but what is documented. And this is when we use our codings, and we're going to talk about that a little bit further in the lecture as well. We're going to go specifically talking about some of these E&M codes that we use, okay? So let's move on to talking a little bit about the E&M codes. So what's important to know when we think about EM services, right? That is, think about the evaluation and management of your patient. You're going to look at coding and documenting appropriately based off of two things. The level of the medical plan that you have for your patient, right? Defined by your services. And then you're going to look at the total time, okay? So we're going to be looking at one, the level of the plan that you have for your patient. And then we're going to be looking at the level of time. So what are some key requirements for this? So when we think about our medical decision making, right? The plan that we have for our patients, that coding is when you're going to see numbers like that 99202 through a 99215. I'm going to give you a chart later on so you don't have to remember it, but I want you to remember this is what we call medical decision making. You're coding based off of the assessment and the evaluation you did on your patient, and the medical decision that you had to make is what leads you to your billing and coding. This is usually a focused documentation that has three components. It's either looking at our problems, and we're going to talk about those numbers and what that looks like. We look at data. We're looking at the complexity of the tests, the orders, the different things that we have to do for our patient. And then we can also look at the risk. We look at management options, treatment options, and risk morbidity. Okay, so this is the medical decision-making based coding. Okay, so let's look at this a little bit when we think about that. You may have a patient that comes in, they're a new patient, or you may have a patient who's an established patient, and that coding is based off of that. Are they new and are they established? And then we're going to get into some more of the details that you're going to look at. We also have what we call time-based. So you can also do the same thing. It's how much time did you use regarding this patient? This documentation shows the total time that you spent on that day with the patient. It can include your non-face-to-face, and it also can include, like if you reviewed labs, testing, you had to write a note, all of that. So there's a way to get reimbursed for your time-based coding. Know that if you're doing either one of these types of coding, your documentation has to support it. Time-based coding, you're going to do just, I'll give you an example. Patient present for lab review. Patient agrees to having a consultation to review their labs. Provider spent 15 minutes face-to-face with patient explaining if it was a CBC, CMP, hemoglobin A1C, thyroid panel, explaining the normal, that all labs were normal, recommended. You're going to go through everything that you kind of educated that patient on. If there were abnormalities, provider spent 15 minutes face-to-face with patient to review labs, reviewed CBC, CMP, and lipids, discussed with patient elevated lipid numbers. LDL was 140. Discussed dietary habits, exercising, increase in exercising too. So do you see how you make your case when it's becoming a time-based? These are those patients that come in and really there's not much you need to do physically, but you're spending time with them explaining something. It can be even those patients, say they're coming in for refill of medication. You just did a physical a couple of weeks ago. And they forgot to tell you they need their medications refilled. You want to do a time-based, you may want to do a time-based on that. And you may be, but you have to then again say, patient spent 15 minutes, 10 minutes with the patient, face-to-face, refilling patient's medications, talking about side effects. It has to be more than just wrote a prescription. Okay? All right. So what are the components of coding, right, on your encounter? You're going to look at the extent of the history. You're going to look at your physical exam, the complexity of your decision making. And when we talk about the complexity, I have a slide later on that's going to kind of give you some pearls about how to kind of gauge the complexity of your visit. Is it a straightforward visit? We call that a level 1 or 2. This is when that patient comes in to see you. They have very few diagnosis codes, right? They're illnesses that can be taken care of at home. If you ever worked in the hospital, it's kind of what we call like those walkie-talkies. That may be the patient that presents just for something like, I don't know, medication refill or birth control refill, right? Or just follow up. They can be pretty healthy. Maybe they have high blood pressure, but it's well controlled. And what they're coming in for that day may be a very straightforward visit. Then we also have those who are low complexity. That is a level 3. We think about those patients who you may be prescribing your over-counter medications and a refill, and then you got to have more of a conversation with that patient. When we think about moderate complexity, that could be a level 3 or 4. That's when you're thinking about prescriptions for a new problem or a worsening or existing problem. And then we have high complexity. That's level 5. That's those who may be admitted to a hospital or for surgery, or they had some type of exacerbation of their problem. These are also those patients that come into your office and they may have many chronic diseases, some of our geriatric patients. And maybe they are on several medications, 5 or more, and you need to reconcile their medications, but they're also having some challenges with their health. So you're going through that as well. Okay? So I want you to remember, straightforward, level 1 and 2 or 2, low complexity, level 3, moderate complexity, level 3 or 4, and then high complexity, level 5. I'm going to show you a chart with a little more detail, but I do want you to kind of think there's that 4 levels when you're thinking about it that way. Okay? So now let's look at how does that look when we think about our EM codes, right? What does that look like? And remember we mentioned earlier in this lecture about that 99205s and 99213s. This is what we're talking about when we talk about E and M coding. So I want you, if you're looking at this chart, you will see going across the top of this chart, there are some numbers going from 99211, 99212, 99213, 99214, and 99215. Think about the slides you just saw prior to this when we talked about the different complexities. Okay? Now I want you to look down the left side of your screen where we have the heading of history, examination, medical decision making, and time. And so I want you to see what's in those. And then if you go across the top now, you can see if you were coding a 99212, that patient's coming in with, you want to make sure that you're documenting what their chief complaint is. You need to do a history of present illness and have at least 1 to 3 elements in that. Your review system is not necessarily necessary, or your past family social history is not as well. But then when you go down to your examination, look at how many elements you need to have in your exam. Okay? And then you can go down to your medical decision making. It will be considered straightforward, and your time is about 10 minutes. So that's a 99212. And if you do that with all of those columns, 99213, 99214, 99215. I just want to quickly, I'm going to allow you to stop this presentation, and you can kind of look and study this chart a little bit more in detail. But look at our 99215 before you do that. So if you're going to bill for a 99215, you must have your chief complaint. You must have your HPI, which has 4 elements to it, right? Or you can have 3 chronic diseases. Review a system has to be 10 systems or more. And then your patient's family and social history has to have at least 2 elements. Your exam has to be comprehensive, about 8 systems. And then your medical decision making, you're saying, is high. And the time you spent is about what they would consider 40 minutes. So as you're documenting, I want you to think about what is required for each one of these. Because legally, if you code for a patient, a 99213, 4, or 5, or any of them, and you have not met the criteria within each one of those categories, then you are misrepresenting what you've done. Because I want you to remember, the coding does not reflect what you have done. It reflects what you've documented. So, as nurses, we always say, if it's not documented, it's not done. So if your documentation does not support a code, one of these codes, you cannot code. You will then have to downbill. So that's why it's important, as you learn to see your patients, all of that work that you're doing, that you're documenting it so that you get paid accordingly. Because many of you may work at a facility where your coding is what your leadership will look at to see why and if they should continue you in the practice. Sometimes your bonuses may be tied to your billing and coding. Okay? And then sometimes some of you may work in organizations where your billing and coding doesn't align, so that organization may send that billing back to you and you have to fix it. So understanding where you may have made a error is important, and trying not to do so. But what the literature has shown us, most individuals, especially advanced practice, we undercode. So we may be doing and documenting 99215s. However, we undercode and we're doing a 99213. So many may say, well, that's okay because we are, at least we're safe. But what it does is the organization in which you work, if it's private practice, if it's in an institution, that means 1, that they're losing money. And 2, undercoding is not always a good thing, right? It can also ring a red flag, right? Or it can raise a red flag. So it's important to understand your documentation, your EM coding, and attempt to do it appropriately. And here's another chart I just wanted to show you where I have those same codings. But one other thing about this chart is it listed according to new patients preventative, established patient preventative, some of the Medicare specific prevention codes, and then some of the CPT codes. When you are doing your billing, not only do you want to document your 99213 because you've seen a patient who has been established in the office, when you look at the criteria, you say, okay, yeah, they're level 3, so it's a 99213. You may need to add some of your CPT codes. This helps your organization, as well as sometimes these are measures that we have to do as providers for people to see that you are doing what you're supposed to do. Think about if you have with obesity. If you're weighing a patient, you're looking at their vitals, you're looking at their BMI, your CPT code that you should be adding to your documentation is a 2022F. It helps your documentation. Remember, we talked in the beginning of this lecture about being concise. So documenting a 2022F helps you to see that you're being concise. You may also want to add the CPT code for a 3075F. Say your patient has high blood pressure and they were obese. So you did check their BMI, you did discuss their BMI, but you also looked at their blood pressure and had a conversation about that. Everything that you're doing, what you're actually doing is you're documenting the services that you're providing. There are many, many more CPT codes. There are CPT codes for education. There are CPT codes for like the blood pressure. There are CPT codes that may be required for Medicare. There's a list of those. But being able to articulate through your documentation the services you are providing to your patients is important. So take a minute, look at this slide as well, because it gives you a little more detail than the slide that you had previously. But the same information is there. I just don't want you to be limited in thinking that your EM codes is all that you have to document. Because you think what you're looking at right now are EM codes for like our preventative care patients, some Medicare CPT codes and things like that. But we also did briefly mention that there is some time coding. And knowing that if you are seeing patients and you are coding based off of time, you want to make sure that you're very specific in that documentation, and that way it will align with the coding that you choose. I have attached here a video for you if you watch this in PowerPoint version, where you can go in and it talks a little bit more about the video. About coding and billing and the importance of it. Some takeaways I would like you to do is, one, the importance of coding and billing. Knowing that when we do our documentation is important not only to demonstrate the care that we've provided, it helps to establish what is the plan for the patient. It helps us to be able to demonstrate what and validate why we did or did not do something for a patient. It is also the way in which we communicate to others within the healthcare team. With that, it is very, very important that we be very clear and concise in our documentation. Recognize documentation includes many different components and factors. And when you are documenting on your patient, when you are assessing your patient, is understanding how the assessment and the care that you provide to your patient should align with the billing and coding that you do on your patient. And when you're doing your billing and coding, that billing and coding can be based off of the management that you're doing for that patient, the plan of care. It can be based off of demonstrating or measuring what you documented. Your billing can be reflective of that. and understanding what needs to be in each section in order to determine what your billing and coding should be. This lecture does not make you an expert. I hope what you get from it is that your clinical documentation is important. It includes and should be considering not only yourself as the provider, you got to consider the healthcare team that you're working with, the insurance companies that you work with, and the government in which we work up under, the governing bodies, the accrediting bodies, right? And at the center of all that is your patient. And knowing that there are multiple individuals who may be looking at your charting, so being clear and concise is going to be important for you. I have also included a article where you can read more about billing and coding just to start to get a little more comfortable. As you are in your clinical setting, please take time to look at the billing and coding that your preceptors are doing so you can then gain an understanding. Ask questions about the billing and coding. Even when you start to practice, reach out to your billers, reach out to your coders. You are not an expert in billing and coding. Most institutions have individuals who do that, but you can reach out to them for assistance to understand it better. I hope this was helpful and informative, but please remember, this is an introduction. There is so much more that you're going to need to do and should do in order to be successful, not only as a clinician seeing patients, but that your documentation is reflective of what it is that you're doing.